between speakers and audience. Agenda 5, summary and closing the event. According to Agenda 1, I would like to announce the opening of the online webinar event and kindly request to present David's comparative presentation.
Hello, Alonde, Mingalaba. Now today we have a very interesting topic, GERD. Most commonly, one of the most commonly seen GI disease. Most common GI disease seen by gastroenterologists, surgeons, and primary care physicians alike. Also very challenging with impact on quality of life of patients and healthcare resources. Today, our understanding of the disease has evolved with very varied presentations, enhanced diagnostic tools, and approach to management. Also, a lot of us are concerned, with the issue of long-term PPI use. So, for all these, we have our eminent guest speaker from Bangkok, Professor Somchai Lila Sorborn. Our MC has already introduced, and I would like to add, he is not only Vice Director, not only Vice President-elect, he has many other posts and many publications in peer-reviewed journals. So allow me to invite Professor Somchai Lila to walk us through these problems.
So thank you very much, Professor Tin May, for your kind introduction. And good afternoon, ladies and gentlemen, and best friend from Myanmar. First of all, I would like to sincerely thank the organizing committee and the DKSH for giving me a chance to join this lecture. I will let you know. I think everybody maybe see the slides. Let me grab this one first. And you can see the pointer, that's right? Okay.
Yes, we can.
Go. Yep. Many thanks. So my task today is embarrassing the current trends for the GERD management, which I will spend about 40 minutes in the next 40 minutes to cover the how to diagnose and manage of a GERD patient. Secondly, I would like to tell the definition of mild and moderate gastroesophageal reflux disease and how to handle a case of a mild to moderate gastroesophageal reflux disease. Thirdly, I would like to let all of you know about the Alginate in the management in the gastroesophageal reflux disease. And last but not least, I would like to update the current guidelines or consensus for GERD management. Let me grab, because I'm afraid about the just would like to make sure that the transmission didn't have any problem about that one. Okay, so I will not video my video, and the connectivity should be okay. And so if you look at the definition of the Montréal classification, the Montréal classification also mentioned about that the GERD is a condition which develop when the reflux of the stomach content causes troublesome symptoms and or complication. And in the Montreal classification, which is quite a little bit old classification, but they're still using this definition. They can divide it into two groups. The first group is esophageal syndrome, and the second group is the extra esophageal syndrome. You will see that in the esophageal syndrome, I think all of you may be familiar with the symptoms syndromes such as a typical reflux syndrome or the reflux chest pain syndrome. And also the other is a reflux esophagitis and stricture, which is a less common in our countries, not only in Thailand, but I think, but also in Myanmar as well. And the Barrett esophagus and adenocarcinoma. For the extra esophageal syndrome, I will not touch in this talk. This cartoon from the Lomfo criteria show the interplay between the esophageal hypersensitivity and the acid exposure in the reflux symptom spectrum. The symptom in erosive esophagitis, which we can know about the erosive esophagitis by using the upper endoscopy or esophageal gastroduodenoscopy. So you have to send the patient to the GI doctor to perform the EGD. The erosive esophagitis are dominated by the abnormal acid exposure, whereas symptoms in the functional heartburn are dominated by hypersensitivity. Symptoms in non-erosive reflux disease and reflux hypersensitivity are related to a combination of both acid exposure and hypersensitivity. So the major role of the PPI is predominant in erosive esophagitis, comparing with the non-erosive reflux disease and reflux hypersensitivity. In contrast, the neuromodulator drug will play a major role in the functional heartburn than the reflux hypersensitivity and the non-erosive reflux disease. The majority of the GERD in Asia is a non-erosive reflux disease. Why I have to say that? Because look at this cartoon, you will see that the prevalence of the non-erosive reflux disease is between 83 and 97, and non-erosive reflux disease remain the commonest manifestation of the gastroesophageal reflux disease in the Asia-Pacific region. Moreover, my study from Professor KL also demonstrated that the majority of the erosive esophagitis in Thailand is a mild to moderate of the erosive esophagitis by using the Los Angeles classification. You will see that nearly 90% of the erosive esophagitis in Thailand is a mild erosive esophagitis. Similar to the data from the Asia-Pacific region show 50 to 90% of the erosive esophagitis in this area is a mild erosive esophagitis. So the first consensus that I would like to address is a consensus in the Southeast Asian regions. The leader of this consensus is Professor KL from Malaysia, and I also one of the steering committee in these articles. We have published this consensus in the JGH Open last year, and we also have a 17th statement. The first statement is that the incidence of the gastroesophageal reflux disease is increasing in the Southeast Asian region. I think all of you may should we agree with this sentence? And we also state that the majority of the cases of the GERD are non-erosive reflux disease, which is I already show you the data. And the other statement is many cases of the non-erosive reflux disease have a poor response to the PPI or have a breakthrough symptoms while on the PPI treatment. why we have to say that, look at the data from the USA and the Asian countries in the GERD patient who received the PPI show the similar direction. In the blue bar is a represent from the Asia Pacific region, and in the pink bar is a representative from the United States. This all of the patient already received the PPI and having GERD. You will see that in a patient who have a PPI already, about 94% of the patient in the Asia Pacific region and about nearly 40% in the USA group still have a breakthrough symptoms. More than 60% still have a nocturnal breakthrough symptoms, and more than 50% need the additional medication. About 1/4 of the patient feeling of their satisfactory with the current medication. So there is a lot of gaps in the management of the gastroesophageal reflux disease. So this is a slide. This is a slide show that the list of the management that can be provided to the patient when you have a gastroesophageal reflux disease, starting with the lifestyle modification. Secondly, we can use the prokinetic drugs and also the mucosal protective agents such as the Alginate or Rebamipide, something like that. The acid suppressing agent is still the mainstay management for a patient who have a gastroesophageal reflux disease, because the main pathophysiology of the gastroesophageal reflux disease is a transient lower esophageal sphincter relaxation. So if you can have any medication that can reduce or decrease the number of the transient lower esophageal sphincter relaxation, it would be held in some patients. Or even you can use the drug that can manipulate the acid pocket that I will show you later. Next is the neuromodulator drugs. I already show you that from the Lomfo criteria, we have the acid exposure, and we also have a reflux, and we also have the esophageal hypersensitivity. So in a patient who have a esophageal hypersensitivity combined, neuromodulator drugs should be another option that we can use. Another management that is not a medication that we can use is like an endoscopic treatment. The magnetic system using the link system, which is quite popular in the European countries, we can use that. And last but not least, we can use the surgical treatment. Starting with the lifestyle modification, in our Asian consensus and our Thailand guideline that was published this year, and in also the American guidelines also state the same direction. So starting with the weight loss or weight reduction is recommended for a GERD patient with overweight or recent weight gain. Why we say that? Because if you look at the study, the weight loss can decrease the time with the esophageal acid exposure into randomized controlled trial from 5.6 to 3.7, and from 9% to 5.5%, and also can decrease the reflux symptom in the prospective observational studies. And moreover, tobacco smoking cessation is recommended because they have an odds ratio about 5.67. The other thing is in a patient who have a nocturnal GERD, we recommend that two things. The first thing is a head of bed elevation is recommended. Secondly, we recommend to avoid a meal 2 or 3 hours before bedtime. This two performance or this two recommendation will be help a patient who have a nocturnal gastroesophageal reflux disease. But routine global elimination of the food that can trigger reflux is not recommended, because the data is not so strong to recommend that. This cartoon shows the meta-analysis of the PPI versus H2 receptor antagonist or placebo for treating of the patient who have an erosive esophagitis. The number in parentheses is the number of the study. Like this one is a 4 study. This one is 27 studies. The red dot is a representative for the PPI, and the yellow is for the H2 receptor antagonist, and the triangle green is from the placebo. You will see that the percentage of the healing in PPI is superior than H2 receptor antagonist and also a placebo. Anyway, the placebo effect also have the effect of the healing rate about 28% at the week 12. So we also state another statement that for the alginate should be considered for empirical treatment for the patient with mild to moderate symptoms of the acid reflux disease. Why we state that, and what is the mild to moderate? I would like to address the definition of the mild and moderate gastroesophageal reflux disease. The diagnosis of a mild to moderate is based on the symptoms and is defined as mild is a awareness of the reflux symptom, but it easily tolerated. For the moderate, the discomfort, reflux symptoms sufficient to cause interference with the normal activity, but it's tolerable. So it means that mild to moderate is not so strong like in the European and in United States patient. So I think in Myanmar and also in Thailand, we have quite a lot of cases of the mild to moderate cases. But anyway, we also state that PPI are still the mainstay of the treatment for the patient with persistent symptoms. I will show you the algorithm later in the after seeing all the consensus. And we also state that the Alginates are a good adjunctive therapy for relief of the GERD symptom, partially responsive to the proton-pump inhibitor therapy. Why we have to state this two statements? Because if you look at the data that is a systematic review and meta-analysis comparing with the alginate versus antacid or placebo from 14 study, you will see that the alginate therapies increase the odds ratio of the symptoms resolution about 4.42 comparing with the placebo or antacid for the gastroesophageal reflux symptoms. The same study also comparing with the alginate versus PPI or H2 receptor antagonist from 5 studies looking at the gastroesophageal reflux disease symptoms. You will see that the odds ratio is 0.58. This is a favor PPI or H2 receptor antagonist. This is a favor alginate. So the data is show that the alginate appear less effective than PPI or H2 receptor antagonist, but the pool estimate was not clinically significant. So it seemed to show that it have a trend to go to the PPI or H2RA, but anyway, it doesn't have a statistical significance. That's why we say that why we have to use in the mild to moderate, we can use the alginate. The next study that was published in the BMC about 10 years ago, looking at the moderate gastroesophageal reflux disease by using the alginate, which name is Gaviscon, and also the omeprazole. Looking at the which one, they're looking at the mean time to the onset of a 24-hour heartburn-free period days, and also looking at the number of the patient free of heartburn for 24 hours. You will see that the difference, no difference between using the alginate comparing with the omeprazole group. Moreover, the study looking at the suppression of the acid pocket by using the alginate, which is using the Gaviscon, you will see that for the day one, when you use the acid, when you use Gaviscon for the acid pocket and pH in the acid pocket, the day one is a broken red rye, and blue rye is a day two. You will see that the day two, the pH in the acid pocket is higher than the day one, quite significantly. But in the non-alginate group, even day one or day two, the pH in the acid pocket is pretty close the same, not have a different as using the alginate group. Moreover, the Turkish reflux study group consensus also reports that they recommended using the alginate as a monotherapy for a patient who have a mild gastroesophageal reflux disease. The study from Japanese group from the Motherbe, this was published more than 10 years ago, also showed that in a patient who have a non-erosive reflux disease, when you symptom resolution of the patient in 7 days or even in the 28th day is much better than in a patient who have PPI alone. You will see that in 7 days, group A is using the alginate plus with the PPI is better than the PPI alone. And in the 28th day, group A is the alginate. Moreover, study from Taiwan demonstrated that in the non-erosive reflux patient, when you use the alginate group comparing with the episode, you will see that the percentage of the patient with adequate reflux symptom relief at the day 28 is pretty close. Moreover, in a patient who have a partial response to the PPI therapy, when you add on you will see that the PPI alone is a yellow bar, and the green bar is a PPI plus regurgitation symptoms. I'm sorry, and a heartburn symptoms and regurgitation symptoms and the dyspeptic symptoms, you will see that the patient who have an add-on therapy is better than using the PPI alone. This is why we said that to moderate case, the alginate is a monotherapy for the first line, so okay, for our consensus. The other medication which can be used is a GABA B receptor agonist prototype. This drug is a baclofen. As I already mentioned to all of you that the transient lower esophageal sphincter relaxation is a primary pathogenesis for the reflux disease. So if you can use the GABA B receptor agonist, it will help you quite a lot. The study from the GABA B receptor show that when you use the GABA B agonist, it can decline about episode by 43% and also increase the lower esophageal sphincter basal pressure. Moreover, it can accelerate the gastric emptying time and significantly decrease the duodenal gastroesophageal reflux disease, which is a form of duodenal esophageal reflux related symptoms. So in a patient who have a regurgitation symptoms as a predominant or have a duodenal gastroesophageal reflux disease or a weakly acid or a non-acid, this might be another option for using to the alginate or to the PPI. But the side, which is quite difficult to use it. Another protective agents I also include in this study, you will see that we use the Rebamipide in to look for the symptom improvement in a patient who have a reflux esophagitis. This is an international multi-center study. We would like to investigate the PPI plus Rebamipide on symptom improvement in patients who have a reflux. You will see that in more than 500 patients, the first arm is using the esomeprazole plus with the Rebamipide. The second arm is using the esomeprazole only. And the primary is to look at the mean decrease in the total symptom score. I will show you that the Rebamipide plus with the PPI in you will see that in the black line, which is only the Rebamipide plus with the esomeprazole. This is the change in the total symptom score, and this is one. Another one is a combination therapy is better than PPI alone over the 28 days period. So in this study, we also conclude that a 4-week treatment course combination therapy was more effective than in the decreasing symptoms of the reflux esophagitis than monotherapy. But I would like to add this study, we didn't see any difference in the erosive esophagitis when you add on these agents. But the symptom is better than you using the monotherapy. The neuromodulator drugs, if you look at the study published by using the SSRI such as citalopram and fluoxetine in a patient who have a hypersensitive esophagus or the reflux hypersensitivity, or in a patient who have a refractory GERD, you will see that using the statistical significantly, but by using the tricyclic antidepressant, which have a 2 study of the noise. I also our study that was published many years ago in American Journal of Gastroenterology using the imipamine for esophageal hypersensitivity and functional heartburn. You will see that we use the imipamine fixed dose 25 milligram for 8 weeks. After the patient, we categorize the patient as a reflux hypersensitivity or functional heartburn, and using this drug for 8 weeks. And the benefit is show that in using the imipamine placebo for the quality, we see that per protocol analysis, p-value is a marginal benefit, is a 0.048. The new drugs like a potassium competitive acid blocker, what is the benefit of this drug for the GERD management? You will see that this is a systematic review and meta-analysis from the 2 study using in the severe erosive esophagitis at 4 weeks. You will see that using vonoprazan, which is a PCAB, is better than using the lansoprazole. This study is based on the non-inferiority study. So if you see that the benefit of the PCAB is better than PPI, but it's still try. And also in 8 weeks for a patient who have a severe erosive esophagitis. How about the update of the guidelines and the consensus for the management of GERD in these 2 years? Have collect about 6 guidelines and consensus around the world. The first one is a consensus statement for a recommendation on the management of to moderate gastroesophageal reflux disease in the Southeast Asian regions, which I already addressed to you some statement. And the second one is a Korean guidelines or consensus addressing about the diagnosis and management of the gastroesophageal reflux disease that was published last year. The third one is a Japanese guidelines, which is published the beginning of this year about the gastroesophageal reflux disease for the clinical practice. And from Thailand, which are responsible for a corresponding other have published in the JGH in the beginning of this year about management of the gastroesophageal reflux disease. The other two guidelines which was published this year is the American College Gastroenterology clinical guidelines for the diagnosis and management of the gastroesophageal reflux disease. And last but not least, the AGA have present with the clinical practice update on the personalized to the so we have 6 guidelines and consensus. So I would like to show you the American guidelines address about the diagnosis of GERD should be based on the symptoms. If the patient did not have alarm symptom, they recommend to use the PPI. See what is going on. One more thing that I would like to address that in a patient who have a confirmed as a GERD, we address as a Los Angeles at B, C, and D, and also in a patient who have a Barrett esophagus longer than 3 centimeters. They also mention about the symptoms which I will not address in this talk, and also mention about the refractory GERD, which if the patient have a refractory GERD, you need to do some investigation such as EGD, and then when the EGD, if they still show the Los Angeles classification B or C or D, or have a Barrett esophagus more than 3 centimeters, this should be a GERD confirmed. And they also address the other tests like use off and on therapy as well. The AGA have a GERD symptoms. You can starting with the using the PPI for the standard dose for 4 to 8 weeks and see what's going on after that. If the patient still have a sustained resolution of the symptoms into the lowest effective dose, but if the patient still need the PPI for a chronic use, how about if you use the PPI for more than 1 year, they recommend that you should do a reflux testing to determine the requirement for the lifelong therapy. For a patient who have a partial or no response to the treatment, they recommend that to assess compliance and increase the dose to double dose from the same PPI. Or you can switching to the other PPI as an OD dose and see what's going on after that. Assessing again 4 to 8 weeks. If the patient have a partial response, you should send the patient to undergo E. For the diagnosis, they have some criteria of the diagnosis. In the past, if the patient have a abnormal acid exposure time more than 4%, we will say that this patient have a gastroesophageal reflux disease. But in the American AGA clinical approach, personal approach, they try to address that, use the prolonged ambulatory reflux monitoring so you can get the more information in that patient. And if you have a more than 1 day of the abnormal acid exposure time more than 4%, this is should be considered as a borderline. But if you have a more than 2 days with the abnormal acid exposure time more than 6%, this we will call the GERD confirmed. So it's changed a little bit. From the journal, from the Japanese group, for the consensus from the Japanese group, they did not mention so many things, but they address the how to use the PCAB, which is a vonoprazan is a one of the PCAB, which is which is developed and produced by the Japanese group, and this is I think maybe nearly 8 years that is available in the market from the Japanese group, and in Thailand we have available this drug about maybe 3 to 4 years. So they try to address that in a severe reflux esophagitis is a vonoprazan or using the PCAB. This is just only the one consensus that try to address how to use the vonoprazan in different situation of the GERD. But in the mild reflux esophagitis, you can using either PPI or vonoprazan. So it doesn't matter, but they try to introduce that vonoprazan should be have a erosive esophagitis. And moreover, in the non-erosive reflux disease, they address that if they did not respond, they will classify as a PPI erosive reflux disease. If you can have the endoscopy and didn't see any abnormality in that patient, and you just doing the physiologic testing evaluation who have GERD but did not perform the endoscopy, you can try the PPI for 2 to 4 weeks ago, the endoscopy. If they have a response, they just discontinue the treatment, temporary symptoms, and see what's going on. If the symptom relapse, just perform the endoscopy after that. For the colon group, it doesn't have a much different from the other consensus. Consensus, you will see that we create this algorithm that in a patient who have the mild moderate gastroesophageal reflux disease, again, mild is the awareness of the reflux symptom but easily tolerated. Moderate is a discomforting reflux symptom sufficient to cause interference with the normal activity, but it's tolerable. If the patient have this problem, you just using the lifestyle modification that I already mentioned to you, and starting with the alginate. If the alginate doesn't have a much improvement, you can use a PPI if the symptom persists, and combination therapy with the PPI and alginate if the partially response to the PPI. Improvement in symptoms, you can use the alginate or intermittent PPI when needed. This is our algorithm. So in our consensus statement in the Southeast Asian region, we also addressed the role of the alginate, as alginate was recommended as the first-line treatment for the patient with mild to moderate GERD, while recognizing that the PPI, the use of the alginates was also recommended as an adjunctive therapy when the GERD symptoms were only partial response to the PPI. Let's move to the final guidelines from Thailand. In our guidelines, we starting with the symptoms suggestive of the gastroesophageal reflux disease. If the patient symptoms such as the dysphagia, odynophagia, recurrent vomiting, or the GI bleeding, or the weight loss, please send the patient to undergo the EGD. But if they didn't have any alarm symptoms, we divided patient into 3 groups. The first group is a typical reflux symptoms, and the third group is an extraesophageal syndrome. In the extra syndrome, please exclude other conditions by sending the patient to see the specialist, like such as if you have a hoarseness of voice, please send the patient to the ENT. If you have a chest problem, please send to the chest man first and see what's going on. By the tip, if the response, just step down. If the no response, same the other guidelines or consensus, we recommend to increase the dosage as a double dose or switch other PPI as a standard dose for 8 to 12 weeks and see what's going on. If you have a normal EGD, please consider other tests like the esophageal pH monitoring plus esophageal testing and see what's going on after that. If they have a lifestyle modification or intensified the dose or using the PCAB in the severe cases. So what are the new in these guidelines or guideline for management? I would like to summarize as this 2 slides. For the diagnosis, the initial diagnosis by clinical symptoms without alarm feature is sensible. I would like to is sensible. So you can diagnose the GERD without any investigation. As such, threshold for the diagnosis of GERD, you will see that the 24-hour pH testing increased cut point for abnormal acid exposure from 4% to 6%, and extend recording day more than 1 day, recommended about 4 days. And in erosive esophagitis, LA A, B, or C, or D, and or Barrett esophagus more longer than 3 centimeters GERD confirmed. For management, in mild to moderate gastroesophageal reflux disease, Alginate is appropriate for initial treatment and add-on therapy to the PPI. PPI is still the mainstay for the management with concerning long-term safety and appropriate timing for further investigation whom chronic use is more than 1 year. Address a role of the PCAB in Japanese guidelines, especially in the severe erosive esophagitis. And in refractory GERD, increasing the same PPI from OD to double dose. Add on other medication is based on physiologic evidence. So in conclusion, Mr. Chairman, ladies and gentlemen, to summarize of the medication that I already mentioned as in this table, this is my personal table that I created. So categorize the patient like erosive esophagitis, non-erosive reflux disease, refractory reflux hypersensitivity, functional heartburn, and refractory GERD. PPI can be used in all of these aspects except the functional heartburn. But if you have a problem about refractory GERD, please you can switch in or increase the same PPI to the double dose, or changing a timing of the PPI, or maybe consider about the PCABs. The H2 receptor antagonist, which is the H2 receptor antagonist, which is a data also show that in the nocturnal acid breakthrough, it can be used in the erosive esophagitis to the reflux hypersensitivity, but not in a functional heartburn, and also in the refractory GERD. PCAB is good in a severe erosive esophagitis, but as on-demand therapy GERD that can be used instead of the PPI. So it might be a next option for to elucidate this recommendation. For the Alginate, in a patient who have a breakthrough symptoms, and in a patient who have a mild to moderate GERD, it can be used. And also in the refractory GERD, baclofen is the same. Rebamipide you can use in the severe erosive, in the erosive esophagitis, but just only the symptom reduction. And in refractory GERD, we didn't have any yet. for the bisalt divider, it might be helpful in the patient who have a GERD. For kinetic drugs, in a patient who have a dysmotility of the esophagus, or have an overlapping with the functional dyspepsia, or have a delayed gastric emptying time, or in a patient who have a prolonged use of a PPI, especially in a patient who have a prolonged use more than 8. In this group, it can be have a delay of the gastric emptying time and also have a small bowel intestinal bacterial overgrowth. So it might be a good option to use a prokinetic drug in this group. Last but not least, the neuromodulator drug is better in all groups of the esophageal functional esophageal disorder. Thank you very much, and I would like to invite all of you to join APDW 2023 in Bangkok, which I will be a Congress president in next year in December 6 to 9, 22-23. Thank you very much.
Thank you very much. A very concise and complete lecture covering mild to moderate GERD. There are a few questions. The first one is,
yeah,
you can see as well, PPI and
let me see. Yeah, the first question. Okay. Can long-term use PPI cause alcohol and subsequent cancer transformation? If so, will you treat? I would say that the long-term PPI use can cause the have some effect to increase the malignancy of the upper GI disease, such as a gastric cancer or esophageal cancer. But after looking at the methodology and the heterogeneity of the study, it doesn't confirm yet that long-term PPI can harmful or have a subsequent cancer transformation. But it have some tendency that this can be turned to the other things, because you already know that the atrophic gastritis also a precursor of the gastric malignancy and also the hypergastrinemia. So, for my opinion, I would say that up to now there is no strong evidence that the PPI can cause the upper GI malignancy related. But we have to tell the patient the truth that it has some linkage of some adenoma or the gastric polyps. So I would recommend that if you can use as long as you have some, you still have an indication. But if you didn't have any indication, maybe just stop it. The long data that we have available in the literature is more than 18 years. So, and the things, if you have a patient who have a long-term use of the PPI and you want to stop it,
no strong evidence that
temporarily negative and have a long-term of the PPI more than 8 weeks. After stopping of the PPI, you will have the hypersecretion effect, which can cause the heartburn, the dyspeptic symptom. That's why the patient did not realize about that. So they try to reintroduce the PPI again because they think that the disease is coming back. But actually, it's not the disease is coming back, but it can cause from the rebound acid hyper. Just tell the patient about the truth and try to minimize or try to check PPI as you can. Action and role of the alginate in gastroesophageal reflux and other GI symptoms. If you look at the study, especially from the acid pocket, the alginate can coat at the acid pocket. So the chance of the reflux event will be decreased in a patient who have a what is the acid pocket? Acid pocket is a phenomenon which can occur after we eat something. When we eat something, the pH should be going up, like from 1 or 2 to be going up to 3 or 4. But study already demonstrated that after you eating, the pocket of the acid going up to close to the EGJ junction, and especially in a patient who have a hiatal hernia, if you have a more chance to have a reflux event. That's why the alginate have a mechanism, a strong mechanism like this one. Action and okay. And is there any study of the effect on GERD and
PPIs.
Is there any study or effect on GERD? Oh, I would say that the study trying I would say alcohol is increase the chance of the reflux event as a if you look at the study, which is a meta and systematic review published about maybe 3 years ago, also show that the alcohol can increase the GERD symptoms. This is depend on the frequency as well. So yes, the alcohol can cause the reflux symptoms, and we also recommend to stop the alcohol as well. Is there other questions? Oh, we also have the role of the H2 receptor antagonist in GERD. Yes, I already mentioned about the nocturnal acid breakthrough. What is the nocturnal acid breakthrough? Nocturnal acid breakthrough patient who already received the PPI double dose. You mean I means that if a patient have a GERD symptoms, you prescribe the PPI one tablet in the morning and one tablet in the evening. And when you perform the pH study in the nighttime period or in the whole day, but in the nighttime period, especially at the 10 p.m. to 8 a.m. in the morning, you will still see the effect of the pH drop below 4 in the stomach more than 1 hour. This phenomenon is called nocturnal acid breakthrough. Nocturnal acid breakthrough is not as a nocturnal heartburn. Nocturnal acid breakthrough is a phenomenon. And in this phenomenon, when you use the H2 receptor antagonist, it shows that the number of the nocturnal acid breakthrough is decreasing. That's why you can use the nocturnal breakthrough in a patient who have suspected to have a nocturnal acid breakthrough. You can add on the H2 receptor antagonist in the nighttime period. But the H2RA can cause the tachyphylaxis. So for me, I would recommend that if you want to add on H2RA in a patient who already received the double dose of the PPI, you should use as a cycle of the H2 receptor antagonist, like 2 to 3 months, and after that stop and using again cause more effectiveness. Yeah. How long should we use a prokinetic for GERD? If you look at the studies, majority of studies have a marginal benefit, but the total pH time of the reflux symptom score also show some benefit. So when you want to use, I would recommend to use just only maybe 4 to 8 weeks, but you already know that 5 or 6 years about how to use the domperidone, because based on the observational study, huge study, which is a study done on more than 1 million people in Europe, also show that when you use the domperidone more than 2 weeks in a patient who have an elderly, they will not recommend to use that because they can cause the cardiac arrhythmia. So, but up to now, for the other prokinetic drugs, such as a Mosapride, Etopide, up to now, the data, Mosapride, you can use that because especially in the Japanese guidelines, Etopide, you can use that. But I would say that not for a very long-term period, because most of the study is talking about a 3 months period. Can I use long-term PPI in CKD patients? Yes, you can use it, but as you already know, in a patient who have a CKD, PPI have a little bit. If you look at the odds ratio of the PPI, it might be aggravate the CKD. So in a patient who have already the CKD, if you use just use as for the any indication, you can tell the patient, but not using it in the long term. If you have to use more than like a long term, like more than 6 months or 1 year, you have to talk to the patient and please monitor the kidney function as well. In pregnancy management, yeah, if you look at the GERD management for the PPI, only omeprazole is categorized as a category. You want to use first line drug, I will use the Alginate, because the Alginate is in the Australian and New Zealand category. The category as a pregnancy category grade A, which is quite safe. So if you use the Alginate in a pregnancy and it didn't work very well, you can use the PPI, but just make a precaution that some PPI is a pregnancy category grade C, but majority of the PPI is grade B. But I will recommend to use the PPI, use the form of the Alginate, which has a potassium like the Alginate, like Gaviscon Advanced. You can use it quite very well in the pregnancy. How to treat the rebound effect of the PPI withdrawal? The PPI withdrawal, you can before you stopping, you can use 2 modalities. Firstly, before stopping, you just using the PPI, changing from OD dose to alternate day for another couple of weeks and stop it. Reduce to the H2 receptor antagonist and use the potency of the PPI, which is have a less frequency of the potency. If you look at the potency of the PPI, Rebamipide is have a PKA is higher than the other one. So the potency of the PKA is better than esomeprazole, is better than omeprazole, is better than lansoprazole, and is better than pantoprazole. Pantoprazole, it seems to have not a very potent as or a Rebamipide. So you can switching to the weak potency before you stopping as well. But this is not a standard recommendation. Just only have 2 studies. The first study is just only using the alternate day for a couple of weeks, and the other study is recommend to use the H2 receptor antagonist in that situation. Or I think if you have a if you want to use the PPI test, you can use standard dose. You can use the double dose. The depend on. You can use 7 days. You can use 4 weeks. The response, the patient it had depend on if the some literature said that if the patient responds more than 50%, this is we have a successful response. Some might using the 75%. It depends on which criteria you want to look for. So I would say that you can use either standard dose or double dose. Duration is depend on 1 week to 4 weeks, but in some study might recommend to 8 weeks. But like a non-cardiac adjustment, 7 days should be okay. But in a patient who have an extra esophageal GERD, 8 to 12 weeks should be better than short duration. May I ask how you manage if GERD and HP infection coexist? Please elaborate more on diagnosis of the non-erosive reflux disease. I would say if you have a HP, it can help you in the GERD symptoms. So in a patient who have a non-erosive reflux disease, treat the patient first and eradicate to Helicobacter later after 8 to 12 weeks because it can help your symptoms. But in erosive esophagitis, you can keep in both group of the non-erosive reflux disease and esophagitis, you can keep HP until you treat to 8 weeks, and after that eradicate HP because some might have symptoms of the GERD symptoms after eradicate Helicobacter pylori, but it doesn't have any significant if you can eradicate HP in the beginning or the after 8 to 12 weeks, it can help you symptom if the patient have a severe symptom. But if the patient didn't have a severe symptom, you can eradicate at the first time. Okay, and please elaborate more on diagnosis of non-erosive reflux disease. Non-erosive reflux disease have to have this reflux symptom first, heartburn and or regurgitation. You do the endoscopy. If the endoscopy didn't see anything abnormalities by using the white light, but some might be mentioned that when you use the zoom or the narrow bench or the face or using the high resolution using the control or anything else to elucidate the vascular pattern or in the IPCL help in some patient that this is have a non-erosive, this is have erosive esophagitis or not. But normally just only the white light. If you didn't see any abnormality, we will think about the non-erosive reflux disease. Moreover, if you do the 24 RPH testing, it should have an abnormal, we will call it non-erosive reflux disease, which have an abnormal acid exposure. But if we didn't see any abnormal in the 24 RPH, but when you look at the pH drop below 4 in the tracing, and we see the correlation of the symptoms and the exposure every time, we will call that we use the symptom association probability or the symptom index. If the symptom index is more than 50% or if the SAP more than 95%, we will call this patient as endoscopy, but abnormal acid exposure by 24 RPH testing. But the reflux hypersensitivity is a normal endoscopy, normal acid exposure, but have a positive about the symptom association probability or symptom index. Okay.
All right. Thank you very much. I think we have come to the.
May I ask how you manage if GERD? Oh, we already did that. How about using the E2 inhibitor in a gas? I think we already mentioned about some of them. Okay. Yep. Professor Tindime.
Yes. Yeah, I think in the interest of time, I think we have almost come to the end. I would like to ask one thing. You have mild and moderate GERD, I know, but have you ever, how many patients do you send for surgery, fundoplication? In like last year? No, never. Okay. Because
no, not never. it's quite a few cases, Professor Tintin. I have sent the patient to do the surgery about 10 cases in my life because majority of the cases can cope by medications, except some patients who need a very long-term PPI. The last patient that I was sent to, that I sent to the surgeon last is a patient who already done the fundoplication and I have a symptom recur after that 10 years. And I did the study about the 24-hour pH by using the Bravo capsule and also the pH impedance, and also show some abnormalities in that patient. So I asked the patient, maybe you have a two choice.
Thank you.
Decided to undergo the surgery again, and it did quite very well. Yeah, less than 10 cases. Yeah,
less than 10 cases in your lifetime, and that's thank you very much. I think you have today highlighted one very important point. In this era of we are concerned for PPI, long-term PPI use, we have very good alternative, Alginate, which you can use as first line or add-on. So this would be very helpful for general practitioners, gastroenterologists. So thank you very much for your concise lecture for highlighting Alginate.
Thank you very much, and thank you all the participants. Thank you, DKSS. Thank you again. Yep.
So bye-bye and later.
Bye-bye.
Thank you, Mr. Somchain, for your scientific talk. Then I kindly request you to present Gaviscon product presentation to you all. Maybe you all know, I would like to kindly remind that Gaviscon is the best choice for your gastroesophageal reflux disease and heartburn suffering patients. Gaviscon is the best solution for GERD, which is mechanical problem. This is because Gaviscon contains unique alginate compounds which serve as red layer on the top of the gastric acids and gastric content. This section starts within 3 to 5 minutes and lasts long up to 4 hours, which is effectively beneficial to your GERD patients. Sodium bicarbonate and calcium carbonate contained in Gaviscon also act as acid neutralization agent. With the combination with PPI, Gaviscon can give the optimizing treatment to gastroesophageal reflux patients who are suffering with residual symptoms with PPI treatment alone or PPI with antacid combination. As Gaviscon is registered over the counter drug, so you can safely use it in many types of patients, including in pregnancies and lactating mothers. As a conclusion, I would like to kindly remind you to choose Gaviscon liquid sachet for a GERD and heartburn patients. Thank you.
Thank you very much. I think we have come to the end of our session. We thank everybody, the speakers, our esteemed speakers, our participants, the questions, and of course, the sponsoring farmer. This is very useful for the community, for the doctors, for the gastroenterologists, for the surgeons, as well as the primary care physicians. So, thank you very much. Good evening.